Welcome to eCancer. We are at AS 2012 in Atlanta, and we have the privilege to share with you the opinion of Faith Davies and Antonio Palumbo, two really myeloma experts that probably will give us the flavor of what is new in myeloma, what has been the more prominent discoveries or advances in the last couple of years, and what is going to be for the future in myeloma treatment. Let me start by asking you how the treatment of myeloma has changed with the introduction of immunomodulatory drugs and proteasome inhibitors. Faith.
I think the whole environment has actually dramatically changed. There's no doubt that over the last 10 years, the overall survival for patients is dramatically improved. The progression-free survival of patients is much better, and their quality of life is much better. And it's not just for the older patients, or indeed the younger patients, it's for all patients that have really made a dramatic improvement. So completely different, I think.
Faith, how treatment of myeloma has changed with the introduction of novel agents, particularly the immunomodulatory drugs and the proteasome inhibitors?
Oh, it's dramatically changed. We've improved the progression-free survival and the overall survival of patients since the introduction of those two classes of drugs. We've also improved the quality of life of patients, and it's not just the younger patients that have been able to benefit from these drugs, it's the older patients as well. So, amazing difference.
Okay, during this meeting, Antonio, there has been an educational session. I would say that a very interesting educational session that you were sharing. And there was a topic about doublets, triplets, quadruplets. Would you like to comment on what is the difference between one and the other options?
Well, I would say that certainly the triplet is becoming more and more a standard in the treatment of myeloma because it's increasing the response rate. We do have data on prolonging progression-free survival. There are some experimental studies on quadruplet drugs, followed mainly by maintenance, but I would say we are, from this point of view, still in an experimental environment. And I would say certainly there is also a role for a two-drug combination, mainly in the unfit, frail population. So today I would say that the free drug might represent the standard for the fit patient not transplant eligible, while the two-drug should be probably considered as a first choice for the unfit patient.
And I understand the three drugs will be the standard for the transplant candidate patients for the induction.
As well. Certainly the free drug is as well for the induction before autologous transplant. We have basically two different paradigms. One is the combination of bortezomib with an alkylating agent, mainly cyclophosphamide or melphalan, and the other is the combination of bortezomib with IMiDs, thalidomide or lenalidomide, depending on the side of the ocean.
Okay. There is a dilemma about efficacy versus toxicity. If I am going to buy a car, I would like to have speed and security. Okay? Then why this dilemma occurs in myeloma? Can we not get efficacy and safety at the same time? Why people say efficacy versus toxicity? This is a question for both of you.
I think that over certainly the last 3 years, we've learned an awful lot more about how to give the new drugs, the IMiDs and the proteasome inhibitors. And so I think if you'd asked me 3 years ago, I would say that we did have a big issue about toxicity, but we're now learning that maybe delivering the drugs in a different way, so potentially subcutaneous bortezomib rather than intravenous bortezomib, and maybe altering the schedule to ensure that we can deliver the drug in a timely way, so maybe going once weekly rather than twice weekly with the bortezomib, actually means that we can dramatically reduce the toxicity and maintain the efficacy. And there's a number of studies now really supporting that approach.
You have been one of the leaders in this idea of trying to reduce as much as possible the toxicity, because this will be critical in order to maintain the efficacy. Would you like to comment on this as well?
Yeah, I would say, if I can make a very short comment, more is better if it's tolerated. So certainly what we have been trying to do in this here to increase the combination, the potency of our treatment approaches, and until a given point when the toxicity is becoming an issue. And generally speaking, you can see it from the different studies. When the discontinuation is around 10–15%, this is acceptable. If it's becoming 30–35%, this is becoming an issue. So we have different studies, different combination, and from that point of view, the idea is in the unfit, in the frail, over the age of 75, when we do not feel confident on a triplet combination, certainly the two-drug combination is the choice to follow.
Okay. I have another question for both of you, but I would like you to concentrate in the young patient, and you, Antonio, in the elderly elderly patients. Faith, consolidation and maintenance is a role. Do you think this is the future or not?
Okay. Again, I think that's been quite a controversial discussion point at this year's ASH. There's very, very clear evidence for both consolidation and maintenance, two large randomized phase 3 studies showing the benefit of that approach in the younger, fitter patient post-transplantation. And certainly there's a dramatic improvement in progression-free survival. A number of physicians have been concerned what might happen with respect to whether patients might have resistant disease at progression, and there's some emerging data to suggest that that's maybe not the case. And so I think for the younger, fitter patient, there is now a move towards giving maintenance and consolidation, potentially, particularly in those patients with high-risk disease.
Antonio?
I would change, if I can, the reasoning, because we have been discussing very much the risk of a more aggressive relapse after consolidation of maintenance. But the other side of the coin is that consolidation might significantly increase the proportion of CR and, let's say, cytoreduction. And maintenance certainly has a major role in delaying clonal evolution. So if from one side may be true that a progression under treatment may be more aggressive, it's certainly true that a continuous treatment is able to delay as much as possible the clonal evolution and the relapse with a definitely clinical benefit.
Antonio, will you update the information on the maintenance part of the MPR trial during this meeting, or when are you planning to update this information?
This meeting, Thanos Dimopoulos is going to update the study mainly on the opportunity to use different agents at relapse, including lenalidomide.
Okay.
The update of the study will be done probably at the end of this year, and of course for this study the question is if the survival advantage is going to show up or not. Regarding, I would like to make a comment coming back to the previous question. In the MMO15 study, 30% of patients receive lenalidomide at relapse, despite the fact that they were receiving lenalidomide during maintenance.
We are talking, yes, for everyone about MMO15, the MP versus MPR versus MPR plus lenalidomide maintenance. Another point, another question that people frequently ask, what about the secondary malignancies, the primary secondary malignancies? Is it still an issue or not?
I think that the concern is still there a little bit, but not so much as previously. It seems to be that the rate of malignancies seems to have plateaued. There probably is a slight increase in patients with MDS and hematological malignancies, but I think the solid tumour one seems to have plateaued. And I think without a doubt, coming back to risk and benefit like we were talking about earlier, the actual benefit with respect to progression-free survival seems to far outweigh the risk for malignancies. I don't know if you
do you want to add something?
Absolutely agree. I think that today there is no signal of an increased rate of solid tumors with use of IMiDs. There is a signal for an increased risk of hematologic tumor, mainly MDS and IML, mainly in combination including IMiDs and melphalan. For combination melphalan-free with IMiDs, probably the increase also of the hematologic tumors is very limited.
Okay, we are just almost at the end of this conversation, but there are two class of drugs that are in the second or third or fourth generation already, are the proteasome inhibitors and are the immunomodulatory drugs as we have started this. Regarding immunomodulatory drugs, pomalidomide is the third generation. Would you like to comment on this?
Yeah, there's the phase 3 data is being released at this meeting, and that was comparing pomalidomide with dexamethasone against high-dose dexamethasone. And that study clearly showed an increase in progression-free survival and overall survival for those patients that received pomalidomide. And it seemed to be associated with very minimal side effects. So I think that we've now got a new IMiD that we can use for the treatment of patients.
Yeah, so I think the information is really very important because they have focused, this trial has been focused on double-relapse and refractory patients, and these are patients that there's really unmet medical need. When they relapse at that time or they progress under lenalidomide or bortezomib treatment, there is no option for this patient, and I think just to have an alternative for them is very important. And Antonio, would you like to comment about carfilzomib, the second generation proteasome inhibitor?
Yes, this has been another major improvement and achievement. Carfilzomib is a second generation proteasome inhibitor, certainly with a much better safety profile than bortezomib, no peripheral neuropathy at all, also less hematologic toxicity, and on the other hand, a slightly increase in efficacy due to a higher proportion of complete response that has been observed in the phase 2 studies. And I would probably also say a faster mode of action. So we now have a drug that might increase the response and the speed of response in comparison to bortezomib.
Okay, I think on top of this, the good news is that this is not the end of the story because we have already oprosomib and we have MLN9708, two oral proteasome inhibitors that probably will make life more easy for the patients because oral medication always is more convenient. On top of this, also we have the monoclonal antibodies, elotuzumab, the data is showing that is very active in combination with lenalidomide. And now we have very preliminary data, but encouraging data on anti-CD38. Then I think for the future for the patients is becoming better and better. Don't you think so?
Absolutely, including our headache in which is the right schema to choose in which condition. But certainly we are living an absolutely exciting period with many new drugs coming, and therefore certainly some major achievement in terms of clinical benefit.
Okay, do you want to add something?
No, I think I totally agree. It's going to be fantastic to have a monoclonal antibody. And so I think we're all really excited about that coming forward. But I agree, it's going to be a headache. But I think one of the good things is that many of the new drugs coming through seem to have minimal side effects. And so hopefully we'll be able to use them in that frail elderly population where up to date we've struggled a little bit. So I think it's good times.
Okay. Then thank you very much. I think it has been a really fruitful conversation with these two experts that has driven us from the beginning of the new drugs, the immunomodulatory drugs, thalidomide, lenalidomide, proteasome, to the end of this road that we are now facing, I think, with a lot of hope for the patients. Thank you very much.
Thank you very much.